Status epilepticus. It is an important emergency which we need to know in detail how to manage as even junior doctors. So what is status epilepticus? Status epilepticus is when a patient comes to you with seizures. It could be a seizure lasting for more than 5 minutes, or it could be a patient with recurrent seizures, recurrent seizure activities where he does not gain or he does not regain consciousness in between these seizure episodes. So both of them are considered as status epilepticus and you have to swiftly manage them. So we need to know what is the definition of a status epilepticus, and after knowing this, now let's go and learn how to manage it. Step 1 of a seizure. The moment the patient comes with a seizure, you need to first start with the ABCDE approach. Airway, breathing, circulation, disability, exposure. Simple as that. Any emergency, that is how you start. So you go with A, B, C, D and E. So first of all, you check the airway. If it is not patent, you need to make sure you take necessary measures to make it patent. So you can use the triple maneuvers: head tilt, chin lift, jaw thrust. If not, if he is patent, if he is breathing, you turn to left lateral. You need to turn the patient to the left lateral. You need to suck out. You need to suck out secretions. You need to give him oxygen via a face mask. You need to suck out secretions. You need to turn him to left lateral and you need to suck out secretions. Then check his breathing. Is he bradypneic or is he tachypneic? If it's okay, no worries. If it's not, you might need ambo ventilation. Then check the circulation. So check the pulse. If there is a pulse, not to worry. If there is no pulse, he might be in cardiac arrest due to hyperkalemia. So definitely you need to go for CPR. Then D, very important. What you have to do is you have to initially check glucose. Never ever forget glucose, because CBS being low, hypoglycemia can cause fits and it's easily preventable. So first check glucose, then quickly check his GCS or even the AVPU, alert verbal response, auto pain or unresponsive. While you are checking that, someone else from the other side should go for cannulations. Need to try to access. Need to try to get the venous access, right? Meantime, once the access is achieved, you need to get bloods. Bloods for what actually? You already checked the capillary blood glucose, so it's done. So then take a VBG. Take a venous blood gas. So that venous blood gas will tell you the acid-base status. Mostly they will be in acidosis because of the fit. Then what do you want to know? You want to know the electrolytes, the sodium and the potassium, and you can get an idea of the calcium also. Okay, a blood gas. Then you send serum electrolytes, calcium and magnesium profile, and then if you have time you take bloods for full blood count and other basic investigations to see if it is due to an infection or not, but that is later on. First we need to manage the active seizure, right? So these things, although I am explaining it with time, these things should happen within a minute or two, right? Within the first minute or two, the moment you assess the patient, these things should happen. Of that E, you see if there is any head trauma, if there is any change in the pupils, if there is any evidence of any other road traffic injuries, he could be having a seizure due to head trauma. We don't know. So just have a general inspection of E and then quickly now we'll go to treat the seizures in step 2. Now what is step 2? Step 2 of the treatment of status epilepticus is you need to start him on a drug which will try to stop the seizure, right? So If no cannula, if there is no cannula, you can use IM or buccal midazolam, IM or buccal midazolam, 10 milligrams stat. IM or buccal midazolam 10 milligrams stat. So you have to use it and you have to wait and see if it is settling. Meantime, try to get IV access. But if there is IV access, you have to go to IV midazolam. IV midazolam 0.1 to 0.2 milligrams per kg bolus. Then what do? You wait for 5 minutes. You wait for 5 minutes and see if it is settling. If not, you repeat. If the seizures are not settling, you repeat it for the second time. Then, at the end of 10 minutes, after 2 doses of midazolam, if it is not settling, then you need to go to second line. You need to go to second line drugs. Now, what are the second line drugs? Let's look at it next. Now, you've been managing status epilepticus. You approached it with ABCDE. You've given the first line, which is the midazolam. You've given it twice. Still the seizures are not settling. So what's the next? So you go for second line. As second line, we have to use anti-seizure medications. Out of that, we have phenytoin sodium 20 milligrams per kg as a fast bolus, as a fast infusion. The rate is 50 milligrams per minute. So it usually goes within 20 minutes, it's in. So then with this you see how it goes. Then in 20 minutes, at the end of 20 minutes, you have to assess what is happening. If you don't have phenytoin sodium, you can use IV levetiracetam. It is 60 milligrams per kg bolus. IV levetiracetam 60 milligrams per kg bolus. And then you wait for until 20 to 30 minutes. And still, if it is not getting settled, now it is called refractory status epilepticus. And then you need to go to the algorithm to manage refractory status epilepticus. So now we are at a point where the patient has gone into a refractory status epilepticus. So now it is crucial that we induce a medical coma, or else, in other words, you have to induce paralysis. You have to go for rapid sequence induction and then intubation and ventilation and continue to keep him in a sedation. So, what are the things we use? IV midazolam 0.2 milligrams per kg bolus. After this, you have to give a paralytic. So, in a case where there is a status epilepticus, the patient will have rhabdomyolysis. They will have hyperkalemia. So, don't risk by giving succinylcholine. Instead, you can use other paralytic like atracurium, rocuronium, right? So, you can give atracurium IV delirium, 25 milligrams to 50 milligrams start. Then the patient will be ready for intubation. Quickly intubate, secure the airway, connect him to the ventilator and continue ventilation. So then, while this is happening, you need to continue IV midazolam infusion of 0.05 milligrams per kg per hour. 0.05 milligrams per kg per hour. So this infusion should go on and he should be sent to the ICU, and at the ICU you need to arrange an urgent EEG to make sure to see if the seizures are settled or what type of seizures, or is it a non-convulsive status epilepticus. So he can still be in status without any convulsion. So it needs specialist intervention. It could be, there are various methods of interventions, and there are other second line anti-seizure medications also, and then the last resort you can go for steroids, biologics, and then IVIG, even plasma exchange also is possible. So this is how we induce rapid sequence induction, and if midazolam is not there, you can even use propofol. So if you are using propofol, you have to use propofol 2 milligrams per kg bolus, and you should give it over 5 to 10 minutes. Sometimes when propofol is given in very high concentrations, the patient can develop propofol related infusion syndrome, where he can go into a bradycardia, sudden cardiovascular collapse. Okay, so that is very rare, but just for information. So this is how we manage status epilepticus. This is a very important emergency which all undergraduates who are going for internship need to know, because you will be getting this in your ward and you have to be confident in how to manage until a senior comes.